Hello everyone, so we'll start part 5 with one simple question. If you have partially threaded cancel screw, what would be the optimal position of the thread, or what would be the optimal length of the threads? So these two screws have the same diameter, and one screw has a 32 millimeter threads, the other one has 16 millimeter threads. So which one is of these pictures is the optimal one? Number A, where you have the threads just past the fracture site, or B, where you have the threads are only few behind the fracture site, or C, where you have the threads are on both sides of the fracture site, or D, where you have the threads distally to the fracture site. You can stop this video and think about it for a second. So the correct answer is D. The reason for that is that D actually gives you the maximum number of threads. It's true that A has more threads, however, at this point where the threaded and the non-threaded portion of the screw meet, this is the run out of the screw, and this point is the weakest point of the screw, and it's not advised that you place the weakest point of the screw at the fracture site where you have the maximum movement. Now, do you need to over drill for partially threaded screws? The answer is no, because the proximal part of the screw does not have any threads. It's not going to engage the proximal cortex. Now we have another question here. You're trying to do an IPJ fusion of the hallux and your screw is spinning. So what do? You can again pause the video and think about it for a second. Well, the right answer is that you remove the screw completely and you place another one that is completely threaded screw, and you over drill the distal phalanx and you do not touch the proximal phalanx. This way you have more threads that are going to engage the subcortical bone of the distal aspect of the proximal phalanx, and this way the screw will catch on strong bone, because in this scenario here the screw is probably spinning within the bone because it's not able to catch enough of the cancellous bone. But if you remove the screw, change it and place a fully threaded screw, now you have these threads catching the subcondylar plate. Partially threaded cortical screws are called also shaft screws because they have a wider shaft here. The width of the shaft is equal to the same diameter of the screw. Do we need to overdrill for these screws? The answer is yes, you need to overdrill for shaft screws because basically this diameter is much bigger than the diameter of the threaded portion of the screw. So you need to make sure that you have enough gliding hole for that screw to be inserted through. Locking versus non-locking screw, which one has a larger diameter? Of course, locking screw have larger diameter because they lock into the plate. They do not count or depend on the depth of the threads. So the threads really are not very important. If we make them larger of the core diameter, then we can have stronger screw. And of course, most of the locking screws have star head. Another important function of locking screws that are utilized, of course, in locking plates is that you preserve periosteal blood supply. As you can see here, this is a non-locking screw, non-locking plate. The screw is directly against the bone, is causing compression against periosteum. If you use, however, the locking screws, there is a space between the plate and the screw, so there is better blood supply to the bone and hence better bone healing. Cannulated versus solid screws. Of course, it's much easier to insert a cannulated screw, especially if you're doing a percutaneous screw fixation. However, it's important to note that the cannulated screws are much weaker than solid screws because you'll have to deduct the diameter of the hole inside the screw from the core diameter to know the actual diameter of the screw. Now let's go back to the previous questions that we started with. If you measure 16 millimeter, you need non-self tapping. You will choose a 16 millimeter screw. However, in self-tapping screw, as you see at the end here, that portion of screw is not complete threads. That portion is very sharp and is responsible for creating the threads within the hole. So the distal portion of screw does not really engage into the distal cortex. That's why you need to have at least two threads of the screw, or at least 2 millimeters of that screw that extend beyond the far cortex, so that you have the full threads engaging the far cortex. Now, if you measure 15, you need a cortical screw. You can always go 16 because you're penetrating the far cortex. However, if you measure 15, you're choosing a cancel screw, you can use 14. You do not need to penetrate the far cortex. In fact, if you choose a longer screw, you will distract the fracture site and make it even worse. Now let's talk a little bit about plates and how screws are used within the plates, but let's start first with the functions of the plates. We have neutralization, compression, buttress, bridging, and anti-glide and tension plates. Neutralization plates is an example of the plates we utilize most commonly for ankle fractures. You have a screw that is responsible for compression across the fracture site, but you need a plate that will neutralize all the forces that might go around the screw, either rotational forces or distraction forces or bending forces. So that's an example of neutralization plate. It's not doing any compression, it's only neutralizing all forces around the screw. Compression plate, on the other hand, they do compression. We covered this part before, and you have to drill away from the fracture site, and you need to bend your plate superior to the fracture site. This way you get more compression across the fracture by doing this technique. And compression plates are usually utilized when you have a fracture that's vertical to the bone surface and you're not able to perform a lag screw technique. Buttress plate, biggest example is your calcaneal fractures. You have a fracture that's very comminuted. You do not want to do any compression because it's difficult to do compression around a comminuted fracture like this. You put a plate that's locking, screws that are locking, and this way the screw is actually buttressing the bone and shielding all stress from the bone. The stress travels from the bone to the screw to the plate and gets distributed equally. This way you give the bone the best chance to heal. Bridge plating are utilized when you have a comminuted fractures, or also if you're putting a plate across multiple joints. You will fixate the proximal part, the distal part of the fracture, and the area of the comminution will not be fixated. This way you don't have to dissect around this area, you don't have to strip the blood supply of the bone, and you give the bone better chance to heal. In addition to that, it's very difficult in the first place to place any compression across a comminuted fracture like this. This is a good example of bridge plating. You use locking plate and screws proximal and distal to the fracture site, and no screws at all through the fracture site. Anti-glide plate is also utilized for a distal fibular fracture. When the plate is placed posterolaterally, a 1/3 tubular plate is usually used for that. You need to place screws proximal to the fracture site. Distal to the fracture site you may or may not. I would recommend that you place also one screw at least distal to the fracture site. This is called anti-glide plate because the motion of the fracture is most commonly in the posterior direction. So if you place a plate posteriorly, you will prevent gliding or the motion of the fracture. Tension band plates, an important example of that is the plates that we utilize on the plantar aspect. Sometimes, of course, not easy, but sometimes if you are planning on doing a lapidus procedure, those plates actually are on the tension side of the fracture because compression is here, tension site is plantarly. Now we can go to part 6. Thank you.